If I'm treating more distal pain in the femoral nerve, typically this will be knee pain, I can target the saphenous nerve specifically instead of the femoral nerve proper. In that case, I'll typically try to find it just under sartorius. In this case, I have the sartorius in the middle of the screen. I'm scanning very medial on the thigh. We can see the rounded femoral artery under the sartorius. And as I scan proximal or distal, I'm looking for a saphenous nerve to be in that vicinity. And we actually see it just to the right of that artery. We see a couple of small bubbles. And as we trace that a bit more distal, now we can see it under the sartorius right there. We go more proximal again. And you see the nerve laying close to the artery again, and here they're separating. So I'll tend to target the saphenous nerve a little bit after it splits away from the femoral artery. Not super necessary, but it makes me feel a little bit better to keep the metal away from the big blood vessels. But certainly not required. The lead isn't going to hurt anything. Here I have the nerve in the middle of the screen again, as mentioned, a little bit distal to where it's left the femoral artery. And I can simply park my lead to the right of the nerve and the vastus medialis, or to the left of the nerve inside the sartorius.
Dr. Ottestad, it's very common in regional anesthesia to be doing blocks for operative or postoperative knee pain at the adductor canal. I mean, this is similar, yes?
Yeah, this is essentially a similar technique. You're finding the landmarks the same way, your needle approach, lateral to medial, targeting fairly close to the femoral artery. Pretty similar to regional anesthesia techniques. Straightforward to learn. Finding the nerve can be a little bit tricky, but that's stated as long as you can find the femoral artery and that sartorius, the electrical paresthesia testing will tell you which of these bubbles on the screen is the correct nerve. And in this case, you can see my needle inside the vastus medialis here. I could go past the nerve and place the needle inside the sartorius for the same effect, and to look for that knee paresthesia.
And similar to lateral femorocutaneous, this is sensory in nature, so...
Actually, that's a great point. If we are stimulating and say I am looking at the nerve a little bit higher where it's close to the artery, at this location, if I were to stimulate here, I probably would get a sensory paresthesia going down towards the medial leg in the saphenous nerve. But if I were to stimulate a little bit deeper here, I may find I'm on the motor branch of the vastus medialis, and the patient may report a paresthesia going to the knee, but I'll see clear motor contractions, and I'll know this is motor stimulation of the vastus motor nerve, not sensory stimulation of the saphenous nerve. So ideally, I'm looking for that sensory stim going past the knee to confirm this is saphenous stimulation, and not direct motor stimulation or motor nerve stimulation.
And then once again, just for the pulse generator, where would you place that? This
placement will be relatively straightforward. Will be somewhere in the middle of the thigh. I tend to prefer a little bit more anterior, so it simply doesn't rub against the other leg. But that's something you can ask a patient for preference. And another really nice tip is you can always take the actual battery pack or maybe a matchbox that's the size of the battery pack and just tape it on the patient's skin as a trial to see if they can tolerate that location.